Hello, everyone, and welcome to this episode of Connect Over Coffee. I'm Runsi, the founder of Ovarcome, and today we are joined by our advisory board member, Dr. Dennis Chi. So Dr. Chi has been the attending surgeon at Memorial Sloan Kettering Center for the past 19 years, so almost a decade, and has devoted his prestigious career to caring for women with all kinds of gynecologic diseases. As the head of Ovarian Cancer Surgery at MSK, Dr. Chi is regarded as one of the finest surgeons, not only in this country, but also internationally and globally. So as our advisory board member, we are absolutely honored to have Dr. Chi with us today. And as he discusses with us the latest and the greatest surgical advances in ovarian cancer, and also his vision for the future. So join us for the next 45 minutes to an hour as we chat with Dr. Chi about all things ovarian cancer surgery. And if you have any questions as we go along, please type in the comment sections below and we will get it addressed post the discussion. So with that, a huge welcome to you, Dr. Chi, and welcome to this episode of Connect Over Coffee. It's such an honor to have you with us.
Well, thank you, Runsi, for inviting me to do this coffee talk. I do want to correct you, though, and unfortunately, it makes me older, but I've actually been attending at Memorial Sloan Kettering for 24 years. So that makes me 5 years older than I'd like to be. I wish it was only 19, but yeah, it's been a nice career here at Memorial for a couple decades.
That's wonderful, and like you said, it's an honor to have you with the coffee chat, and I do have my coffee with me. So join us for this coffee hour for some great discussion. So, Dr. Chi, my first question is, what is the role of surgery in ovarian cancer? Just getting to the basics, and both in early stage as well as later stages of the disease. And can you help us break this down in basic terms for all of us to understand clearly?
Sure. That for a lot of diseases, the diagnosis of cancer isn't made surgically. You have a lump on your breast, you have a biopsy, you have a colonoscopy that shows a polyp that proves to be cancer. So the diagnosis is made usually before you get to see a surgeon. For ovarian cancer, it's different because we cannot make the diagnosis generally by sticking a needle into a fluid-filled ovarian cyst or tumor, because that could potentially spread it. So the role of surgery is multiple. One is to make the diagnosis. Oftentimes a patient comes to see us with an ovarian tumor, ovarian mass. I'll talk more about that in a second. And the surgery is done as the first step of treatment, but also to diagnose the ovarian cancer. So in early stage disease, that means that the abnormality is confined to the ovary. There's no other sites of abnormal tissue. And so we do what's called a staging procedure. We take out the initial site of disease, the tumor. We usually send it to the lab and they say, yes, this is an ovarian cancer. And then we do what's called a staging procedure where we take biopsies from throughout the belly to determine if the cancer is confined to the ovary, stage 1. Or it's spread to other places in the belly, stage 2 or 3, or sometimes 4. In cases where that's about 25% of cases, maybe a little bit more. In about 2/3 to 3/4 of the cases, though, oftentimes the patients come to see us with not just an ovarian mass, but an ovarian mass and obvious tumor nodules outside of the ovary. In that situation, again, the surgery can be done to make the diagnosis, but then also it's not what's called a staging procedure. That's the first step in treatment, but what's called a debulking or a cytoreductive surgery. That's the first step. And then that procedure, that surgical procedure, we try to remove as much of the cancer as possible before somebody starts on chemotherapy.
Thank you. And so a little bit going in depth into how the timing of surgery and residual disease at surgery may influence the disease outcome. So I was just recently reading that the amount of residual disease that's left at surgery possibly can predict the survival outcomes for patients. Tell us a little more about that. How critical is it to reach that R0 for longer survival of patients?
Yes, I mean, this is something that I've spent the better part of the last 2 decades trying to study and figure out how to improve the outcomes of patients who have advanced ovarian cancer and go to debulking or cytoreductive surgery. And so what we found after decades of studies, both prospective and retrospective, is it is important how much cancer you start with. But from a physician point of view, we really can't control how much cancer there is at the start. That's how the patient presented. We can't control the age of the patient, or whether there's cancerous fluid called ascites, or what the inherent sensitivity of the cancer is to chemotherapy. But the only thing in our power to be able to make an impact on an individual patient is when we do the surgery in general, in a big picture, the less cancer that's left at the end of the surgery, the better the prognosis. So that's why this idea of how much cancer is left, how much residual disease is left at the end of the surgery, that's why that's so important prognostically. And so there are different philosophies towards doing this surgery. Some places want to just do as minimal surgery as possible and not hurt the patient. Other centers are more proactive at trying to remove as much of the cancer as possible, even if we have to take out a piece of the intestine or some disease in the upper abdomen. But no matter what, an individual person, if that person is left with less cancer, then that's the one thing where we doctors can have an impact on what her future prognosis will be. Again, the less cancer left at the end of the primary debulking procedure, the better the prognosis.
And you mentioned that the way this is determined may differ based on centers. So like you said, some centers are more proactive than the others in going all in to reduce as much as possible the disease. So in your opinion, what is the best approach? Would you go for the minimally, I mean, just getting down to the R0 is critical, regardless of what the state of the patient is? Or like what I'm trying to understand is, how do you determine if this patient is able to take that, proactive and very serious surgery, for the lack of a better term, and who are the patients who may not be able to tolerate the whole spectrum of it?
Sure. These are questions and issues that I speak about all the time in the United States and abroad. And that's the question of, okay, we understand if you can get all the cancer out before they start the chemotherapy, that's the best thing. But does one size fit all? And the answer is no. Not every patient should have the surgery done first. In some situations, you want to give chemotherapy first to shrink it down. Not all, but in some situations. And the most important thing is that the patient, whenever we do these debulking surgeries, in the back of our minds is always, we want to prolong the quantity of life for this patient as long as her quality of life is also good. So for instance, if the cancer is involving lots of the intestine, and to get all the cancer out, we would have to take out too much of the intestine and give somebody lack of good absorption of whatever she eats and drinks. And so she always has diarrhea, or she has to have a bag. We don't think that that's necessarily a good quality of life. So we balance the surgical aggressiveness of the surgery with the idea of like what's going to be this patient's quality of life. And that's kind of what is a little bit of the art of doing these surgical procedures, is understanding, okay, I can get this cancer out, but then it's going to have this consequence later. And so should I do it or shouldn't I? Generally speaking, it's the amount of intestinal tract involvement that's the rate limiting step as to whether we're going to do an aggressive surgical debulking, or whether we're going to stop, or whether we're going to decide to not even try at the beginning, but maybe start chemotherapy and then do surgery later. Other factors include the health of the patient, comorbid medical conditions, the age, and the general nutrition of the patient.
Okay. So I was just reading recently, there were some published reports on the MIID SOC trial, which says that, which help us understand which basically talks about the laparoscopic surgery following the neoadjuvant chemotherapy, whether or not that's feasible, safe, as well as effective, and how does it provide similar outcome as open surgery in ovarian cancer? Help us.
Yes, this is a paper or study that was presented at the most recent Society of Gynecologic Oncologists meeting. And based on studies, retrospective studies and multi-center studies in the past, the investigators wanted to see what would be situations where you could do minimally invasive laparoscopic or robotic surgery after chemotherapy and thereby decrease the recovery from the surgery compared to the traditional open approach. And there's no question that if you get the same result with what you're removing and what you're not removing via minimally invasive approach, it's better in terms of recovery, restarting chemotherapy, pain, et cetera, et cetera. And so they did a very nice job of trying to predict what situations with minimally invasive surgery be helpful or not. That being said, I'm not a huge advocate of a one size fits all where everybody should have minimally invasive surgery. I think a lot of criteria need to be met, and at this point in time, the long-term results with the minimally invasive surgery in this setting are not in yet. We don't know if those patients who have minimally invasive surgery and the surgeon thinks he got all the cancer out, we don't know if those patients would do as well if at the patient, as compared to if that patient had an open surgery and the surgeon was able to look around the bowel, look behind the liver, look behind the spleen, and really try to get that complete removal of all the tumors. In other words, as I say, and as Jill Seng said, when she reviewed the paper at the Society of Gynecologic Oncology meeting, a surgeon can't remove, he can't resect what he can't see. So, and if you can't see behind the bowel, behind the liver, in between crevices, then how good is the surgical outcome going to be? I wouldn't say this is definitely not something that should be pursued, but it should be studied with caution because we certainly don't want our patients to suffer and be left with cancer after the surgery when it could be removed if they had an incision.
Thank you so much for clarifying that. It helps us understand the differences, and also to your point that it really depends person to person, patient to patient, and that needs to be determined by her physician which approach to take. So thank you for that clarification. So as the principal investigator of so many multi-center trials that you are running or have run to improve surgical management of ovarian, fallopian, and peritoneal cancers, tell us about a few of your ongoing or planned trials and what they are trying to accomplish.
Well, one of the biggest topics in our field of surgical debulking for ovarian cancer, surgeons love the idea that they can do a debulking operation and then start the first chemotherapy in the operating room. So one of the, and I guess this is a play on words, the pun, one of the hottest topics in our field is giving heated chemotherapy at the time of the surgery. We just completed a prospective randomized trial of heated chemotherapy at the time of recurrence of ovarian cancer. And so we're going to publish that paper pretty soon. And I think I can say that there were some admitted flaws in this paper, and we didn't show the benefits that we thought we may, but there was some flaws that we made in the statistical design, like regarding like the dose of the chemotherapy. We didn't want to hurt anybody, and whether they got enough chemotherapy after the surgery with the HIPEC for recurrent disease. So there's definitely some things that we could improve upon on that previous study. We are currently going to embark in a multi-center international trial of giving heated chemotherapy at the initial surgery after their primary debulking, if you will, where you get almost all or all the visible cancer out. Can we improve outcomes by giving chemotherapy heated to 41 to 43 degrees right there and then in the operating room?
Right after the surgery.
Right before the abdomen is closed. That's what HIPEC is. So you can imagine, part of me is very, very excited to do this trial, but part of me is also very tired of 6 to 8, 10 hours of surgery. And then we have to add 2 more hours of giving chemotherapy. But if it's going to benefit the patients, we'll get it done and we'll do it. There are other trials that we're working on. We're trying to determine at the time of the surgery. It's been shown that in animal models that stress, it's secreting certain hormones, has a detrimental effect on cancer growth.
Mhm.
So we're going to try to do a trial where we try to decrease the immune response to stress at the time of these surgeries by giving what's called beta blockers and following certain parameters to see if decreasing stress at the time of the surgical procedure will have a beneficial effect on outcomes. We're doing, of course, the primary HIPEC trial, and another key trial that we're doing is we're studying something called exosomes. It's very exciting, and it's a trial that we're doing with people across the street at New York Hospital Cornell. Dr. David Leiden's lab is the one who's the primary site that's going to do the testing. And exosomes are tiny little particles of DNA. And from my thinking of ovarian cancer and other cancers, it's that you have one cell, it becomes 2 cells, and then 4 cells, and then 8 cells, and then it grows into a big tumor, and then it shoots off baby cells all over the place. The exosome, as best I understand it, I'm not an expert on this field, is that it's more like the way an army would attack. So if I'm an army and I set up a base, then I say, okay, I want to go attack that area over there. Let's send an airplane or a chopper for reconnaissance. Then let's send like a group of 5 to 10 guys on the ground to spy, and then set up a new camp. And then we'll move all our troops to that area. So the whole idea of exosomes is that when you develop a metastatic site of disease, it's not the whole camp that moved. It's not the whole clone of cancer cells. It's certain particles of DNA go as reconnaissance, and they start setting up camp, and they start laying the matrix and the groundwork so that later the metastasis of the whole DNA of the cancer goes there. That's the way I understand it as per David Leiden. So we're going to try and study that and try to see if can we detect in early stage disease or even in late stage disease, these exosomes that are setting up the camp for the metastatic sites to go. And if we can we somehow interfere in those exosomes going from the primary site to the metastatic site? That's actually, it's not going to be ready for prime time for quite a long time, but the preliminary data in other cancers is that is one of the mechanisms of metastatic disease. And so that would be definitely something that we could target to treat patients with metastatic disease, which, as I told you, is 2/3 to 3/4 of our patients with ovarian cancer.
Right. And so you mentioned 3 different kinds of trials. So in terms of when you expect the results to come out, and I know that you said it might take a little time. Are we looking at the next 5 years, or is it longer?
Yeah, I think some of those trials, especially the immune response and the stress bundle, as we call it, that would be back in a few years. We've done other quick trials like that, how to decrease infection, how to decrease the need for blood transfusions at the time of surgery. Those are just a couple of the 2 or 3 of the trials that we're doing, but we're always kind of turning over new trials and developing other ones. And those are 3 that are just starting now. And some like the HIPEC trial, that would probably take at least 5 years to accrue all the patients and do the analysis.
So a quick question on the stress, to reduce stress at the time of surgery. And that's the trial that piqued my interest. So what kind of stress do you see in patients before the surgery? And what is this trial trying to do in terms of, I know that, you are trying to alter or improve the disease outcome by reducing stress. So what kind of stress do you usually see, and what intervention methods are you using or designing in the trial to reduce the stress at the time of surgery?
Well, one key thing is that when you have pain, you release certain hormones, certain corticosteroids, and they call it like the fight or flight response.
Mm-hmm.
So when you're scared, you have certain hormones that are, I guess the layman's term would be adrenaline. You release adrenaline, so that makes your heart go faster and your hands get clammy and the blood flow goes to certain areas. So some of the things that we're doing is giving patients epidurals and different kinds of anesthesia that would kind of decrease that response. We're going to be able to monitor that when you release certain hormones in the blood because of stress, where you can kind of check the blood and see if the measures that we're doing, like the epidural, we're even doing some meditation and Eastern medicine techniques to kind of decrease the stress of the patients before and after the surgery. But I think pain control is a very, very important one. And so the epidural will be part of the approach. We already do the epidural now, but now we're actually going to be studying it in relation to decreasing stress, not just decreasing pain, but it kind of goes hand in hand. Chances are, if you have less pain, you're going to have less of a fight or flight response, and you're going to have less stress hormones floating in your system that may have a beneficial effect on your cancer.
Mm-hmm. Thank you for that clarification. So moving on to my next question. So how do you determine the right candidates for second and third surgeries in cancers that have ovarian cancers that have come back, and how do you design their treatment courses? And also, please tell us about the second look surgery in ovarian cancer. I understand that there was a lot of data published on whether or not this is the right approach, and has this been discontinued or still ongoing? Share.
Yes, let me speak about the second look surgery first. The second look surgery was done oftentimes because at centers like ours, we did a lot of that. We used to do surgery, the primary debulking, then give 5 or 6 treatments of IV chemotherapy, then do a second look surgery. And depending on the outcome of the second look surgery, we would then put in some tubing to give intraperitoneal chemotherapy directly in the belly, not the high pick that I spoke of before, that's during surgery, but starting 2 or 3 weeks after the surgery, there's tubing that could give chemotherapy directly in the belly. It's my personal opinion that that's actually a really good way to treat this cancer, but it's fallen out of favor because more recent trials showed that at first it was thought that it was a good idea to give it right away, not after 6 treatments of chemo, but during the initial 6 treatments of chemo. A good friend, Deb Armstrong, published GOG 172 that showed the benefit of that. But then more recently, with the Avastin trials being the drug Avastin being added to the primary treatment, more recent trials of comparing IV chemotherapy to IV plus IP chemotherapy when you add Avastin, those trials said that if you use Avastin, that the IP chemotherapy doesn't really give you that much benefit. And so I think the general consensus is that it's really not of much benefit, and it's really the IP chemotherapy isn't really used very much. How does that go back to the second look surgery? So if there's really no treatment that we're going to give after the initial 6 cycles of chemotherapy, no IP chemotherapy or nothing, if we're not going to use that information, then it's not thought to be of any benefit to do second look surgeries now just to determine if cancer is still there or not. The distinction of giving chemotherapy is more based on clinical grounds. So there is no maintenance treatment that would be given after completion of the primary chemo based on the second look. So we flat out don't do second looks anymore.
Okay.
As far as secondary side reduction, there are 2 trials, one from the NRG published by Rob Coleman, and another one from Germany. Actually, there's 2 others, one from Germany and one from China. And so they're all a little bit different. The GOG, NRG, Rob Coleman study said that there is no benefit to doing a second debulking on patients. Again, that was had a lot of Avastin being given. The German study by the AGO said that there was an improvement in what's called progression-free and overall survival. And the study that was recently presented at ASCO by the group from China said that there was an improvement in what's called PFS, the time of remission, but the data was too premature to analyze overall survival. But we're kind of akin to the AGO group, and the way we put this all together, and I know Rob Coleman's a good friend of mine, he doesn't necessarily believe that this is the reason for the difference, but it's what we do, is that there was a difference in who were operated on in these 3 trials. In the German and the Chinese trial, they were very selective in who they operated on. Whereas in the NRG, GOG, Coleman trial, there wasn't really any stated strict criteria. If the surgeon and the patient thought that they could benefit from a second surgery, then it was done. So I think that the one thing that all 3 trials can conclude is that a second debulking shouldn't be offered to everyone. I think they all 3 agree on that. Not everybody will benefit, not one size fits all. But I do believe in the German and the Chinese trial that say that if you select your patients well, there's going to be certain patients that should have a second or will benefit from a secondary side reduction. And if it's done in a center that does a lot of these comprehensive Some people would say aggressive surgeries, and they have a lot of experience and the infrastructure that the patients will do well, then it's something that should be considered. And we at Memorial Sloan Kettering, we do have selection criteria, and we don't offer a second or third debulking to everybody. But if you meet those criteria, then we'll do our best to kind of get a complete cytoreduction. And in our experience, those patients do quite well.
Wonderful. So as you have talked about, we understand that all patients may not fare equally from surgeries of any kind because of factors like their age, their other considerations, even like ethnic backgrounds, etc. So that may play a role in the surgery outcomes or even the complications. So can you tell us a little more how you make those determinations in surgical candidates and any unique approaches you use to reduce post-operative complexities in women that may have varying physical status when they come to you?
Well, we have a lot of programs here. For instance, in women, all women who are 75 or older, they see what's called our geriatrics team. And then the geriatrics teams evaluates them. And most of the time they say that the patients can tolerate the surgery, but we would tweak their postoperative care like in this way or that way. So sure, even though we shouldn't age discriminate, it's not wise for us to think that an 85-year-old is going to tolerate 6-7 hours of surgery the way a 25-year-old marathon runner would. So we do have to take age into consideration. And the first thing that we would do is make sure that from our geriatrics colleagues that the patient could tolerate a surgical procedure. We use epidurals very, very frequently when we're doing any kind of major laparotomy, because again, the stress of the surgery, but also when you have pain after surgery, you use a lot of narcotic pain medicines that can lead to mental status changes, slow return of bowel function. So there's a lot of problems with that. And there's a whole big movement called EROS, which is a kind of a program where you try to get the patients off narcotics, decrease IV fluids, get them up and moving and get them out of the hospital. And we kind of use that in addition to all of the other things that I said. As far as selecting patients for the surgery itself, if we think they can tolerate the surgery, there's patient factors that I just talked to you about, how the performance status is, medical comorbidities, age, and then there's tumor factors. So if somebody has, unfortunately, metastatic disease in the chest, then there's no benefit to us doing another operation in their abdomen. It's kind of an all or none phenomenon. Get all the cancer out that we see, or it's not thought to be of benefit. So one thing would be that they would have to have disease confined to where we were going to operate, number one. Number two, if you have a lot of if you have 1,000 cancer cells and or tumors, maybe we wouldn't operate. If you have like maybe a handful of cancer cells, then maybe we would. So there has to be some practical aspects of how theoretically could we get it out. And another thing is that if in general, your prognosis is better, if your cancer comes back in 2 months, your cancer is probably a little bit more aggressive and less responsive to treatment than it happens if it comes back in 2 years or 7 years. So we use that to our advantage. And maybe some people would criticize this, that we only operate on those people who have a good prognosis. But sure, to operate on somebody with a bad prognosis when we don't think surgery is going to help, I mean, that's futile. Why would we do that? So one of the major selection criteria is that we think a patient has a relatively good chance to get through the surgery, has a relatively good prognosis, has a relatively long survival expectancy, and we want to make that even better with the surgery. We're not trying to say that we're going to cure all with the surgery. We're trying to say, use the patient's tumor biology and maximize it so that it lead to the longest survival for the patient.
And thank you for breaking this down so well. So my question would be that for someone that, maybe the cancer has spread to other organs, right? In those situations, what you are saying is that patient may or may not be the right candidate for surgery, but it could be given chemotherapy first, and then if it reduces, but actually there's some positive outcome, only then it makes sense it's relevant to have a surgery. Otherwise, if the disease has spread way too much, then it's likely not going to benefit with an aggressive surgery.
Well, just like in the initial setting, there's not thought to be any benefit to doing surgery on somebody with primary, advanced, or recurrent ovarian cancer and taking out part of the cancer. It's not thought to be a benefit. There is a time, unfortunately, we call it palliative surgery, when patients get a bowel obstruction and we have to help them eat. It's a different story. But as far as debulking or cytoreduction, it's kind of an all or none phenomenon. If you get out 50%, you're not helping. You need to get almost all of it out to move the needle.
Thank you. And we know that getting surgery done by gynecologic oncologists can be critical in the path of recovery for our overcomers. So can you tell us why our overcomers should choose a surgeon who's experienced in gynecologic surgeries, and what questions should they be asking of their surgeons prior to deciding right fit? And also, what should they be prepared for in terms of surgery, not just from a physical recovery standpoint, but just from the planning standpoint, etc. I know it's a lot of questions into one. But
if I forget, if I ramble on and I don't answer your question, please just pull me back and get to answer the question that you want me to answer. As far as it is really important, in my opinion. I mean, there's the drugs that you get are very, very important. But the reality is, if you get the drugs from Dr. A versus Dr. B, assuming that they're good, reputable doctors, the drugs are going to be the same. But who does the surgery is very, very different, and their tenacity, their philosophy, and their approach are going to be different. And I can tell you that because you can't play that like that movie Groundhog's Day. You can't have one surgeon do the surgery and then see what happens 5 years from now and then have a second. But what I can tell you is my own self. I'm a better surgeon now than I was 5 years ago. And 5 years ago, I'm a better surgeon than I was 10 years ago. And I don't think I did a disservice to the patients that I operated on 10 or 20 years ago. But I think that, people with surgery, it's a skill set that gets better with time. Of course, when you get too old, then you maybe shouldn't be operating. But so I think that it's very, very important that people understand that who your surgeon is very, very important. Not just that person, but the team of surgeons behind them if they need help. And the other thing, as far as picking a surgeon, is that there's a lot of cancers, for instance, like pancreas cancer or gallbladder cancer or stomach cancer. When you do surgery for those diseases, any cancer outside of the original organ, any metastatic disease, it's a no-go. In general, the pancreatic operation is called the Whipple procedure, where you take out a lot of different things with the pancreas. If they see cancer spread, they don't do the operation. And as I told you, the majority of patients with ovarian cancer have cancer spread when we operate. So it's a totally different philosophy. And so if you think that, well, I can go to a general surgeon who takes care of pancreas cancer or colon cancer, there's a different mentality. We know going in, we're going to deal with metastatic disease. Let's deal with it. Let's be prepared. Let's call the liver surgeon, the stomach surgeon, the pancreas surgeon. Let's be ready to do the best possible operation for this patient. And I'm not saying the other people don't, but they just don't have the experience and the mindset and the knowledge of the tumor biology and the pattern of spread to deal with that. So we see it all the time. Somebody has what they think is an umbilical hernia, and they go to a general surgeon, and the general surgeon tries to fix the hernia, finds diffuse cancer all over the place, and says, go to a chemotherapy doctor because your disease is spread and it's not surgically removable. And we end up, if the surgeons see them, we end up getting a good result with the surgery because we understand that this is all part of what we do for these patients.
And that's so critically important. Thank you for sharing. So just asking that, if we are in a position where we are trying to determine who is the best physician, the surgeon for us, then what kind of questions, top 5 questions that, an overcomer should be asking to understand the right fit for her, while she's looking for the right surgeon.
So, yeah, and this is where I think the whole time that I've been speaking is all about common sense. And so ovarian cancer, if you look at the staging for ovarian cancer, stage 1 and 2 is not too frequent. Stage 3 and 4 is disease spread to the upper abdomen. So it's so funny to me. For decades, a patient would go to a doctor and the doctor would say, you have stage 3 disease. And okay, so stage 3 disease is defined as what? So disease in the upper abdomen. And then the surgeon would do the surgery and say, well, I couldn't get all of the disease out because there was surgery in the upper abdomen. Well, you knew that ahead of time. You said to the patient, you have stage 3 disease. So why weren't you prepared to deal with disease in the upper abdomen? That's the definition of what you were dealing with, stage 3 ovarian cancer. And I mean, it was all, including Memorial Sloan Kettering. So I think a question to ask is not just the typical, how many of these surgeries do you do? But doctor, I understand from my reading on Google that stage 3 disease means this disease in the upper abdomen, like on the diaphragm. If you found disease on my diaphragm, would you take it out or would you leave it and say that's unresectable? And if the answer is that's unresectable, then I don't think that surgeon is going to have the philosophy to do the best operation that can possibly be done.
Wonderful.
And that's the question I'd ask.
That's a great question to ask. So, so what are some of the key things that our overcomers should watch out for as they get released home after surgery, and what should they report in terms of reactions, side effects, or red flags that they should be reporting to their healthcare team pretty immediately?
When it comes to ovarian cancer, I just gave a talk for a group in France, and I don't know if they got my joke, but you remember the 1970s, the Brady Bunch. Jan was very upset because her older sister, Marcia, was overshadowing her all the time. And she just said, I just hate it. Everybody's always talking about Marcia. Marcia, Marcia, Marcia. So how does that relate? When it comes to ovarian cancer, it's bowel, bowel, bowel. Mm-hmm. Bowel is the reason why patients come to see us, because they have some vague GI symptoms, bloating, they think, not losing weight, not having normal bowel movements. Bowel is what we worry about when we operate, that we can't get all the cancer out. And bowel is when we take the bowel out or take tumor off of the bowel. Bowel is what gives us complications in the hospital, slow return of bowel function because of the morphine or whatever the drugs are taking, or just the anesthesia. And bowel is what gives us problems after surgery. And also bowel, unfortunately, at the when the cancer recurs, that's the thing that is very, very difficult, is when they get a bowel blockage. So when you leave the hospital, or even in the hospital, if you've had an ovarian cancer operation, every day we're going to ask you, did you pass gas? Did you pass gas? When you call and you say, I'm not feeling well, the question is going to be, did you pass gas? Did you pass gas? And the reason being, we're not trying to be vulgar. We're just trying to make sure that the bowel function is normal. You should pass gas every day. You may not necessarily have a bowel movement every day, but you should pass gas every day. And if you don't, and it goes multiple days with no gas, no bowel movements, that's a sign that you could be partially blocked or have a slow return of bowel function in the hospital, after discharge, or even during chemo or at another time. And the other thing is fevers. If you have fevers after surgery, that's a sign of infection. So those are the two big ones: bowel symptoms and fever.
Fever. Okay. So we talked about this, that you mentioned in what situations surgery would not be recommended for ovarian cancer patients. So in those situations, do you provide any guidance on the treatment course, or is it at that point up to her oncologist to pretty much design the treatment pattern for her? I think
it varies. There are many GYN oncology surgeons who also give chemotherapy. At my center, we're pretty much the surgical type approach. We do give the chemotherapy in the OR, the high-PEC chemotherapy, but that's the only chemotherapy we give. As a GYN oncologist, though, unlike a lot of other surgical oncology specialties, we are required to kind of have a baseline knowledge of chemotherapy. And the bottom line is that patients who develop recurrent ovarian cancer, they're put into one of two groups. One are what's called platinum sensitive, and another what's called platinum resistant. And in general, if your cancer comes back within 6 months of completing your platinum-based chemotherapy, then that's what's called platinum resistant. And if it's greater than 6 months, it's platinum sensitive. And the reason why that's important, we're not trying to label people just for the sake of labeling, but if you're thought to be platinum sensitive, then two things. One, you would be a candidate for a second surgery, but also from a chemotherapy point of view, we would consider giving you platinum again, because studies have shown it can be effective in retreating. But if you're what's called platinum resistant, it makes sense. If your infection is resistant to a bacteria, resistant to an antibiotic, why would you give the same antibiotic? So similarly, if you have platinum resistant recurrent ovarian cancer, you wouldn't get platinum again. They would change to different drugs, and platinum wouldn't be one of the 2 or 3 drugs that you'd get. Okay. So 2 big groups, and then the medical oncologist would decide platinum sensitive. Okay, we'll give carboplatin and Doxil, carboplatin and gemcitabine, carboplatin, gemcitabine, and Avastin, like in the Oceans trial, things like that.
Okay. So you did touch upon HIPEC. So I'm just going to ask you just a quick question on HIPEC is, from what I understand, that this has really not gained too much ground over the years, and that this process is better for certain types of ovarian cancers versus the others. So can you please help explain, and what questions should our overcomers be asking of their surgeon if they are interested in the HIPEC treatment?
So I think that right now there are some centers who will give HIPEC for different kinds of histology, ovarian cancer types in different settings. Right now, the only the NCCN guidelines are national cooperative group that kind of has a bunch of oncologists meet together and come up with recommendations. You don't have to follow the recommendations, but they're very, very knowledgeable people, obviously, who give some recommendations. And the only setting where HIPEC is thought to be is recommended or accepted by the NCCN is where what's called the study by Van Driel was published in the New England Journal, where you have neoadjuvant chemotherapy for advanced disease, get 3 or 4 treatments of chemo, and then what's called interval debulking. You do the debulking operation, and then you give HIPEC at that setting. We currently do that here at Memorial Sloan Kettering Cancer Center off protocol. So you don't have to sign up for any IRB approved protocol. Anything else, at least in our institution, we feel is not necessarily experimental, meaning that we've never done it before. We don't know what the results are. Just investigational in the sense that we don't know. We can do it safely, but is it going to move the needle? Is it of benefit? Mm-hmm. So that's the only place where I think that there's strong data to support doing it off protocol. Does that mean that if other centers do it for other situations that it's wrong? No, but it's not necessarily supported by prospective randomized data. The cancers that are specific to what we do that would potentially be a benefit are what's called epithelial ovarian cancers. So germ cell ovarian cancers, granulosa cell tumors, stromal tumors of the ovary, other kinds of ovarian cancers other than serous are probably not going to get as much benefit to getting HIPEC. The data is in serous high-grade ovarian cancer.
Okay. So in terms of exciting advances or things that are happening in the pipeline that might move the needle on ovarian cancer surgery, how do you see it evolve in the next 5 years, and what do you think it's going to change in the ovarian cancer surgery space?
Yeah, I think it's the Solo 1 trial by the NRG that showed that in the upfront setting, if you had a BRCA mutation, that getting a PARP inhibitor as part of your initial maintenance was of extreme benefit. I think that has really moved the needle. Let me just say that it's moved the needle in the following way. There's maybe what's called a germline mutation for BRCA patients, and there's others who have what's called a somatic mutation. And so and there's also something called HRD, which is a kind of a protein deficiency in those cancers. So if you take those 3 groups of patients and they get this PARP inhibitor, their progression, what's called progression-free and overall survival, is really, really far. And so it moves the needle definitely for that group of patients. And that group of patients, but on the other hand, that group of patients is maybe 45% of all the patients. But when you move the needle so much for that group of patients, then the overall survival is going to move, because those 40% of 100% are going to do very, very well. That being said, I do think that there needs to be more focus now on the 50 or 60% of patients that don't have HRD, don't have a BRCA germline or somatic mutation, because that's a lot of patients, and they're somebody's relative, and they deserve to get just as much cutting edge treatment as possible. And so in that regard, I think immunotherapy and other kinds of precision type medicine may be of help. I don't see anything that's that's right around the corner that is going to have the impact that the PARP inhibitors have for our disease in the next 2 or 3 years. But the thing is, we started with the 20 years ago, PARP inhibitors weren't anything. And now it's been shown to be a benefit in the recurrent setting, now in the primary setting. So as we start to move forward and do the molecular biological analysis of people's tumors, I'm hoping that we'll come up with PARP-like drugs for people who don't have the BRCA and the HRD. We're not there yet, I'm not going to lie, but we're moving in that direction. They're up next.
Wonderful. Tell us about your book.
Which book is that?
The one that I think you co-published with a few other authors on the surgery, ovarian cancer surgery approaches or something.
Yeah. Because we're working on a book.
Multiple books?
Yeah. So there's a Principles and Practice of Gynecologic Oncology. That's a textbook. That's one of the leading textbooks in our field. And I took that over from Rich Barakat, who took that over from Bill Hoskins, all Memorial Sloan Kettering guys. And that's a more general textbook, and it doesn't focus just on ovarian cancer, but all gynecologic cancers. There's another textbook that I'm working on called 50 Debates in G1 Oncology. Who gets chemotherapy first before ovarian cancer or surgery first? Who gets PARP inhibitors, things like that, and have leading people in our field doing like 3-page debates on those subjects. But I think the book that you're talking about is Surgery for Ovarian Cancer that Rob Bristow is the first editor along with myself and Beth Carlin. And that's a really, really comprehensive book on who should go to surgery, what the data is on surgery for ovarian cancer, and it goes into surgical techniques that the other 2 books wouldn't necessarily go into. The interesting, funny story about, not funny, but heartwarming story about that is Rob Bristow and we give, along with Bill Clivey, a surgical conference for people around the world to come and work with us on cadavers and videos and learn how to do surgery. And one time a person from a G1 oncologist from somewhere in Europe, I forget exactly where, came to the meeting and told Dr. Bristow specifically, I wanted to take care of a patient with ovarian cancer, and I read your book, and it inspired me to figure out how I was going to manage her, and I managed her very successfully based on your book. So it was very, very heartwarming to us to know that somebody that we didn't even know in a country that we didn't even know the book was being published, read the book and was able to very well take care of an ovarian cancer patient. Very heartwarming for us.
That's wonderful. So my last question to you, and this has nothing to do with surgeries or treatment, but it's more like your message of overcoming to our audience and our overcomers that are listening today.
I'm sorry. Repeat that question again.
What message of survivorship and overcoming and inspiration would you give to our overcomers that are watching today? Sure.
And this goes along to what we talked about. Whether you've just been diagnosed, you have been diagnosed with recurrence. I mean, my wife is a great shopper. I mean, when I go to a store, I just go, I buy it, and I leave. My wife looks at this store and this store and that store. And so people will shop around and make sure they get the best possible product or whatever that they want for their shoes or their bags or whatever. And I don't think that patients should doctor shop. It's kind of not so good to get 5 different opinions from 5 different G1 oncologists in Manhattan. But I do think that people need to not just be recommended to go to their general gynecologist or their family practitioner's person and go with the first doctor they see, and not do the same research that you would do when you're buying something in the store. You need to be your own advocate. If you have a potential for ovarian cancer, this is much more important than a pair of shoes or a bag. Make sure you do your research. Make sure you talk to people. Make sure you find out who your surgeon is, whether they're going to do the right surgery, whether they have experience to do it, and be your own advocate so you get the best possible care. There is a difference in the outcomes of ovarian cancer with who does your surgery, where you get treated, and how aggressively they treat you. And that's what my message to those people out there is. I hope nobody ever gets ovarian cancer, but if you do, Be your own advocate and try to get the best possible care you can. And we're out here. I'm doing this. We're out here. We're trying to spread the word. There are people who care. There are people who want to help you, but we don't know who you are. You got to call us.
That's right. Thank you so much, Dr. Chi. That was such a powerful message, and you shared so much with us today. We really, really appreciate your time and your guidance, and most importantly, your knowledge. I know that our audience and our overcomers will greatly benefit from all the information that you shared with us. So thank you for your time. And overcomers, we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep talking about ovarian cancer, because you know that together we can overcome. Thank you so much, and bye.
Thank you.